All right, we'll go ahead and get started. Welcome back to Grand Rounds for the Department of Medicine at Washington University School of Medicine. I'm John Hickman. On behalf of our chair, Dr. Frazier, Drs. Costco, Spencer, and myself, I am so thankful to have you here for our talk today. And we very much appreciate the feedback that everyone has provided to Grand Rounds thus far. Some suggestions encouraging more information regarding local health disparities has led directly to our talk today. So please keep that feedback coming. It's very useful to us. It truly is an honor to introduce our speaker this morning. Dr. Will Ross currently serves as an alumni endowed professor in the Division of Nephrology. He initially received his BS in biology from Yale prior to medical school here at WashU. He then continued training at Vanderbilt before returning for his nephrology fellowship. Here at WashU School of Medicine, he is the Associate Dean of Diversity, and he has been just a constant advocate for inclusion and health equity. He is known to all of us in the residency as an exceptional mentor, teacher, and leader, and we are just privileged to have him join us this morning. If you have any questions, please, as always, send them along through the chat or the Q&A function as we go. I will help moderate with him afterwards, but for now, please help me give a warm welcome to Dr. Will Ross.
Thank you, John, for that introduction. Good morning, an icy good morning to everyone. Hope you're all staying safe and out of this weather. Great, and I really look forward to talking to you and really getting your questions about what's going on in St. Louis. A lot of us have been here for a long time, and we've seen the persistence of a lot of the inequities in our region. We wonder when this is going to actually change, or when will the transition occur when we as an institution, as a region, can cross St. Louis landscape and say every individual has reached their full health potential. Why is it taking so long? Philosopher George Santayana said that those who don't learn from the past are doomed to repeat its mistakes. And I'm hoping that we can learn from the past. So I'm going to delve into some of the issues both in contemporary St. Louis, as well as the landscape that was established almost a century earlier that resulted in the persistence of these inequities. I have no relevant disclosures. What I hope to do, this is a sophisticated audience. Most all of you have been exposed to the social determinants of health, and so that doesn't need to be covered. What I really want to relate to you is the depth of the engagement, the current engagement of Washington University, our health systems, and other entities with the community, the greater St. Louis community. A really historic collaborative that is aiming to ameliorate these disparities. I want you to gain the knowledge of how to connect your patients to services beyond that which we offer here at Barnes Jewish Hospital and our allied hospitals. And I'm hoping that we, all of us, the medicine department, can collectively work in regional partnerships that promote health equity through a collective impact framework. And certainly, and not least, I hope that this inspires you to engage with the community, to volunteer and serve in ways that will be impactful. Let me start out with a case. A patient I saw in the renal clinic a few months ago. This patient, 68 years old, female, who came in with type 2 diabetes, hypertension, CKD stage 3. I hadn't seen her in clinic for several months. She showed up that one day, and she was hypertensive, blood pressure 210 of 103, poorly controlled diabetes, last hemoglobin A1C was 8.5, and her renal failure had worsened. Creatinine was up to 3.8. When I went to the room, she was crying. She was distressed. And I kind of assumed that the fellow had had mentioned dialysis was inevitable, and that she was just trying to, really get her hands around that inescapable conclusion. But I was wrong. I sat down beside her and I said, "What's happening in your world? What's going on?" I hope you all get the sense of that question. It's a real different question than what's wrong with you. I was asking to be invited into her world using that trauma-informed lens of what's happening. And my goodness, she responded. And she just let it all out, those catharsis. She talked about the fact that her grandson had been killed last month, and that her son was shot and killed a year ago in a drug-related incident. She was obviously depressed and not taking her medications. This allowed me to really think about how can I provide the resources to get this woman out of the depths of this remarkable psychological trauma, and to get her focused on self-care and chronic disease self-management. Of note, and I'd add parenthetically, she lives in zip code 63113. Let's remember that, okay? I'm going to get back to that zip code, among other zip codes. And as I said, I've been at this for a long time, 3 decades, if not more, here in St. Louis, watching the persistence of these inequities. And inequities, they're not just race-based, they're really across the spectrum. When we look at disadvantaged communities, low-income communities, we're in immigrant and refugee resettlement areas, as we all know. We have to look at that community also and see that certain individuals, a number of those individuals, are also not reaching their health potential. Unfortunately, here in St. Louis, a quarter of residents live below federal poverty line. What does that mean? Federal poverty is $26,000 for a family of four, $26,000 for a family of four, and a quarter of residents do not reach that benchmark. We also know that we're plagued with chronic diseases due to smoking, and that lack of exercise, obesity, and as a consequence, we're more likely to see our St. Louis residents die of these chronic diseases. Now, as I prepared for this talk, I had to go back and dust off some of my favorite epidemiology textbooks. I love this one. If I showed it to you, it's all dog-eared and dusty and pencil in. And it's a fantastic textbook that I use to this day. And I hope that we can then now look at the principles of epidemiology and apply those principles as we create a framework for the elimination of health disparities. But that framework in epidemiology asks these pertinent questions: where, when, how, and why. And that means that we're going to go deep and ask where, when, how, and why, so that we, in the end, will have a path forward for so many of our residents. But what are the potential sources of health disparities? These are not new. I mean, I think this is, again, a very mature, highly sophisticated audience. We know about the health barriers due to economic issues, notably lack of insurance, access to care in St. Louis, perceived quality of care. Now, these 3 areas of insurance, I'm going to put in one bucket, and that's healthcare. But we know that in order to make a population healthy, we have to focus on all those issues that surround and support healthcare, those social and structural determinants that are responsible for 80% of a patient's health. So we're going to talk a little bit more about those. The low health literacy, discrimination, stereotyping, and here in St. Louis, racial distrust, racial animus. Now, while I said I was going to talk mostly about those social determinants, I think this audience should know a little bit about the insurance status here in St. Louis, Missouri, as of now, as of February 2012. Just comments about the plight of the uninsured. Let me go back here, sorry. We know that those who are uninsured or underinsured are less likely to receive preventive care, diagnosed at more advanced disease stages. And once they're diagnosed, they receive less therapeutic care. Now, what is the state of the uninsured here in Missouri? Well, it doesn't differ from the state of the uninsured in the country. If you look at this profile on the left panel, you'll see that the overwhelming number of individuals who are uninsured are working families. They're not working one job, they may be working two jobs, if not three. They're low income and they're primarily adults, and there's a significant number of ethnic minorities. Now, with the passage of the Affordable Care Act in 2010, right when we reached a peak of the number of uninsured of 46.5 million, you can see in the panel on the right that the number of unemployed began to drop. Thank goodness. We reached a nadir 6 years after the implementation of the Affordable Care Act in 2016. But notice something peculiar in this graphic. That trend line is going upwards. It's upticking. Well, why? We actually have the Affordable Care Act. Well, I think we know why, right? We still have a significant number of states that have not implemented Medicaid expansion. Only recently has Missouri implemented Medicaid expansion, and there are remarkable challenges here in Missouri. So, when we think about the eligibility for Medicaid, what's happening here in Missouri, and how does it affect our population who are uninsured in Missouri? I want you to pay attention to the last part of this graph, looking at the eligibility threshold for parents. You can see that at the bottom of the line graph there shows that the eligibility of parents who are in Medicaid expansion states is 138% of poverty. However, even though we've voted on Medicaid expansion through a voter referendum almost a year and a half ago, we're nowhere near the stage of having full implementation. And as a consequence, Medicaid in Missouri, parents with incomes up to 21% of federal poverty level are the only ones who are mostly eligible. 21%. Now let's do the math, right? So federal poverty is what, 26,000 for a family of four. 21% is tantamount to $5,000 a year. Individuals who make more than $5,000 a year are not yet eligible for Medicaid in Missouri. We're hoping to make that work. Here's data from the Center for Health Economics and Policy here at Washington University. And I want to compare two states, Oklahoma and Missouri, because they both passed Medicaid expansion about the same time. Oklahoma has, through their efforts, included 200,000 individuals on their Medicaid rolls through their efforts. Here's Missouri. If you look at this panel, since on the left, looking at the inception, the passage of Medicaid expansion, you see the numbers of individuals who were added to those rolls increased only modestly. Again, after another court ruling, step up. But for the most part, that expansion has been notably sluggish, such that as of 2/11/2022, we only have 64,000 individuals enrolled on Medicaid through our Medicaid expansion. We're projected to have 274,000. So guess what? We've only enrolled 23% of that population. I want you to think about all those individuals who are eligible for Medicaid, who are out there not receiving a service and having a lack of access to all the resources that we need. Now, let's move to the next stage. I thought that was really important that I covered that part because of all the new developments on the political front. And let's talk a little bit more about the social and structural determinants that really place our patients at such a disadvantage as they seek to reach their full potential. We're aware of those social determinants. And for the most part, these determinants are the framework on the left outlines these determinants. And these are very broad categories of economic stability, education, neighborhood and built environment, social and community context, and healthcare access. We're not going to cover health and healthcare access because health and healthcare access is necessary, but really not sufficient to really provide the level of services needed to elevate the population that we're interested in. Now, I'll give you an example of those disparities, and this is here in St. Louis. Let's go back to our index patient who came in with all those comorbidities and was having a difficult time navigating all the trauma from the violent events in her life. She took a bus to see me. And I want to contrast those individuals who move back and forth through public transportation compared to those who navigate through car. If you look on the right here, you can see that public transportation actually engenders about 60 minutes or more of travel time. A third, when you look at those individuals who are using public transportation, you can see that a third of those are taking that 60 minutes. 60 minutes. Now, that's best case scenario, 60 minutes. Some of our patients have to take 2 buses, a transfer. Let's double that. Now, let's be really candid here, right? A patient shows up in a Center for Outpatient Health at 4:15. Her appointment was at 3:30. The nurse says, okay, should we see this patient? She's 45 minutes late, and it's at the end of the day. And what do you say? That's rhetorical. That's theoretical. I want you to reflect upon that. What do you say? I hope that you look at this data, and I hope this data informs how you would respond to the nurse's question. Now, here's what's happening in St. Louis. I mentioned this historic collaboration because guess what? We're tired of doing the same thing and having the same effect. And we recognize through the creation of a new entity, the St. Louis Partnership for Health and Community, that it's time to really work across our political fault lines, across our health fault lines, and really converge as a regional community to address these disparities. St. Louis is a very fragmented city, right? There are 28 wards in the city, even though the population is declined to 310,000. I mean, there will be hopefully a move to reduce those wards to 14 from 28, but that still is a lot. And we know that there are 88 municipalities in St. Louis County, 88 different mayors and 88 different ways of doing things. So how can you really come together to work on a comprehensive approach as a region to reducing health disparities and health equity? We've tried some things in the past. We've tried to talk about aligning the city and the county. Well, that was a difficult effort. I have the personal scars to show that was hard. And so we decided that let's just work here in our healthcare and public health sector. And through this partnership, we endeavored to bring in the health systems, including our own health system, BJC, who have to create a community health assessment every 3 years under the Affordable Care Act, as well as the city and the county health departments and other entities, including the Regional Health Commission, Integrated Health Network. And we got together at a table and said, we're representing this broad constituency across this region. We've been doing the same thing for so long. Can we focus on creating a regional community health assessment and a regional community health implementation plan? Can you imagine the impact that would have on all our communities, not those who are underserved or disadvantaged? And so that was a wonderful effort. Some of the organizations represented here on this slide actually provided a framework in the past, including my good friend Jason Cornell, who's here at DJC now, through his approach, through his efforts with the For Sake of All program, the St. Louis Action Plan 2039, building on the work of the Ferguson Commission, provided an approach to addressing these social structural barriers. The St. Louis Equity Index, EI, was created in 2018 to really look at the Social Vulnerability Index and ask, what can we do then to address these highly vulnerable communities. I'm going to talk a lot more about Think Health and just some of these others. The Rapid Response Team and Prepare STL were developed in response to the COVID pandemic, way of providing all communities the appropriate information, as well as access to resources, social resources, as well as health resources across the region in a collaborative manner. And then, of course, I have to allude to the Flourish initiative by Generate Health, which used to be the St. Louis Maternal Child Health Coalition, which is focusing on reducing disparities in infant mortality. These are all now regional efforts. This is what we should be proud of. We've stepped up. We're making a difference by doing this collectively. Now, let's go back to my epidemiology background. You know, what is the issue here? What are we dealing with? When, why, how it's all developed? When we created the Regional Health Commission in 2002, we put together a series of geocoded maps to look at the issues that we were facing. And asking how then do we look across the region and talk about appropriate reallocation of resources to uplift those communities that are under-resourced. And this was one of the first slides we generated, looking at poverty rates across the St. Louis region. And you can see highlighted in the red the areas that were high poverty. This is no surprise to anyone, right? You know, we know where Del Mar Boulevard is, and you can see that the overwhelming zip codes above Del Mar are in red with a slice going South Corridor. We know who lives in the South Corridor. Those are primarily a lot of immigrants and refugees who come to this city. We're proud of our first Americans here. But there's a difference in this poverty between what we're seeing here on the south side and what we're seeing in the north. This is first generational poverty on the south side. These individuals, you know, remember the Boston community that came here in 1990, almost 80,000 plus so far. That's first generation poverty. They're going to assimilate and really move out. Here, north of Del Mar, that's intergenerational poverty. That's painful, persistent, intractable poverty. Individuals who have nowhere to go, and a loss of hope. That became really apparent to us. Now, just to remind you that that was not just an old phenomenon. Here's an update from our colleague Chris Prainer, who pretty much came to the same conclusion when this slide was produced in 2020, basically showing the same distribution of poverty. Now, we know, all of us know, that with that geocoded map, knowing where the predominant individuals, predominant group that is burdened by health disparities resides, and in St. Louis, that is a black-white dynamic. We're talking about a black-white dynamic. Why? Because when we look at the burden of disease, the disproportionate burden of disease borne by a particular community, a particular population, in St. Louis, that happens to be African Americans. When we look at the impact in terms of lost lives, preventable lost lives, as well as the economic impact, which affects all of us, that group is the African American community. And so we will talk about this black-white dynamic, not to abandon the needed discussion on all the other groups that are here in our region, the Latino, Hispanic group, the new immigrants and refugees. So as I said, you can layer any health inequity on that prior map, and it will light up with the same distribution. Homicides. Look, the map looks quite familiar to what we saw before. Even COVID infections. No surprise, right? COVID deaths should be no surprise. I wasn't surprised. Back in 2008, I had an opportunity to work with a group on looking more at a granular level, the zip codes that had the worst social vulnerability index, the highest rates of social lack of social access, social services access. And this map was generated by the health department at the time. And I want all of us to remember 4 zip codes, 4, that really lit up like a Christmas tree when we looked at those areas that were plagued by these historic inequities and had the worst indicators of overall health. Those zip codes were 63106, 63113. Incidentally, 63113 is a neighborhood that we call the Field neighborhood in St. Louis. 63115 and 63107. You all should remember those zip codes. If I see a resident, a fellow walking through the hospital and pull you aside, and I'll say, what are the 4 zip codes that have the highest rates of chronic disease and burden of poor social services? You would say, here they are, Dr. Ross. You would know those. When you interview your patients and you're doing your social history, you must, I emphatically state, you must ask these questions. What, you can look it up. You must know those zip codes. We do have some unique challenges here in St. Louis. And first and foremost, okay, let's talk about the 600-pound gorilla in the corner, racial animus, racial distrust. It's been with us since the founding of St. Louis. And we have to be attentive to that if we really are sincere about moving forward in a progressive manner as a region. These other challenges, we all, again, quite familiar with that. The limited dedicated funding for healthcare, a limited dedicated funding for public health. Missouri ranks dead last in funding for public health. We're 50th. Our public health funding is $6.60 per capita. Let me put that into context. Washington State, where I have family up and down the northwest corridor, their public health funding is $115 per capita. So you see, we're coming at a competitive disadvantage here. The low levels of coordination, which we're beginning to address, and the decaying urban core, which we also are beginning to address through our remarkable efforts to stabilize our neighborhoods and to revitalize our neighborhoods. St. Louis, there is a lot to unpack here, and I hate to say this, but we really have become a case story for how to do things wrong. I feel bad about saying that, but there are a number of historical scholarly reports and contemporary reports, including these 2 fine books by Colin Gordon, one mapping decline, St. Louis and the Fate of the American City, another book by Walter Johnson, The Broken Heart of America, St. Louis and the Violent History of the United States. Colin Gordon's book, Mapping Decline, really goes into detail about the history of redlining and restrictive covenants that prohibited the movement of African Americans and other groups, Jewish groups, Italians, Germanic, German groups here in St. Louis. It wasn't just African Americans, but he talked about those zoning restrictions, most of which were deemed unconstitutional, but they persisted in practice, maybe even to this day. Walter Johnson's book The Broken Heart of America, really talks about, unfortunately, the violent past of St. Louis, going back to the Civil War, maybe even before the Civil War, and how that violent past really fractured this community to this day. If we don't acknowledge that violent past, we won't know how to redeem ourselves and to create a much more inclusive St. Louis. I alluded to a social vulnerability index, a measure of how to look at a community and say, is this a healthy community? And I think it's important because this social vulnerability index takes into account all of those social and structural barriers I mentioned, including structural racism. And so this index goes from 0 being the best to 100 being the worst. Let's look at real briefly some of the elements of St. Louis City, and I dare say St. Louis County because it doesn't differ in terms of where we are in this social vulnerability index. You can see that, in terms of those individuals who are below the poverty line, 22, 23%. Look at the individuals in multi-unit housing, upwards of 20%. Those without vehicles. Remember I showed that slide looking at transportation? 60 minutes or more, a third of individuals have to take 6 minutes or more to get where they want. Some have to do that twice. And you can see that amplified in this graphic in terms of who doesn't have a vehicle, who lives in a single parent household, unemployed. And that this is particularly interesting. 15% of our community in St. Louis lives with disability. 15% are trying to navigate through wheelchair accessible roads and trying to navigate public transportation. So now, I hope you're with me so far. I've thrown a lot at you. We're now going to pivot a little bit. I just want to give you some hint of some of the persistent disparities. And then we're going to close giving you a walk in history so you can understand some of those forces that were at play that created this milieu that we're seeing now that gives rise to these health inequities. If you want to look at the health of a population, any population across the globe, yes, you can ask one question: what is the status of maternal child health? And you will know the health of that population. You can be in Haiti, you can be in Ethiopia, you can be in South Africa, you can be anywhere. And I've asked that question across the globe. And it's given me a sense. Well, here we are in St. Louis. If you look at this, in terms of infant deaths, so this is a time frame from 2008 to 2018. That black-white ratio is 3. There are threefold higher infant deaths in the Black population compared to the white population. Here in St. Louis, there are zip codes. You remember those zip codes, right? Where you can see health disparities that are upwards of 18 to 20 deaths per 1,000 live born. I've seen deaths, infant deaths, much lower than that in rural countries across the world. Here's another graph. I don't know if this is going to display well. Looking at one of the most, I think, disturbing trends in maternal child health in the St. Louis region. I want you to focus on figure 4 on the right panel. And you can see we're looking at maternal health, which includes maternal mortality, maternal deaths, as well as infant prematurity and infant deaths. And you can see that in the white population between 2010 and 2014, there was a 63% decline in those adverse outcomes of maternal and infant deaths. In that same time period, there was a 48% increase in maternal deaths and infant deaths in St. Louis. This is a recent phenomenon. This is very disturbing. This speaks volumes about the health of our community. Now, let's talk about these indicators a little bit more. In 2018, St. Louis City embarked on an approach to really look more collectively at these social and structural barriers and created this equity index, which really encompasses the social vulnerability index that I alluded to earlier. Now, I want to tease out some of that data, just to summarize the condition that we're facing, we collectively are facing. One of the indicators was access to healthy foods here in St. Louis. We're aware of the food deserts, particularly in those North St. Louis districts. When we look at the percent of population with low access to healthy food, that disparity ratio is 1.8, 1.9. So African Americans are considerably less likely to have access to these nutritious foods offered through some of our larger grocery stores. Let's look at educational attainment, a really major determinant of the health of the community. And this panel, we're looking at the number of students who are enrolled in schools where more than 50% of those students meet the state standards for English and math. Now, you would consider those schools to be the high-performing schools. Here in St. Louis, there would be Metro Academy, the Collegiate School of Medicine, bioscience, for schools like that. Well, what is the percentage of African Americans enrolled in these schools? We're doing a little bit better with the collegiate school, which our institutions have found and support a few years back. But nonetheless, if you look at the disparity ratio, it's 5.3. African Americans only account for 4% of that population. So they're 5 times less likely to be represented in those schools. And unemployment, again, we know what's happening here, even as we recover from the COVID contraction of our economy. African Americans are almost 5 times more likely to be unemployed. I'm going to skip this slide. I've already talked about poverty. The final slides on this equity index are around this whole concept of bank loans. And we talked about this whole concept of redlining, drawing, literally taking a red line, that's where the term came from, and drawing a line around a certain neighborhood and states that if 70% or more of this group is white or black, then no one else can move there. That was one of the redlining, but there are so many others, neighborhood groups that came together and stated that we don't want any African Americans or Jews or Italians or Germans or other groups in our community. And the banks followed that practice and denied loans to individuals. And in this panel, you can see, if you look at the number of home purchase loan applications, 20% of black applicants were denied those loans compared to only 5% of white applicants. The same holds true with loan applications. 46% were denied for blacks compared to 20% for whites. Now, of all the data that I've shown this morning, this is also one of the most worrisome, because this is data from 2016 looking at that mortgage lending. You can recognize this map. And in this map, mortgage loans are highlighted by different colors of purple, from light purple to almost to this deep purple, showing the number of homes, loans per 100,000. You can. I won't ask anybody where Delmont Boulevard is, because I think you know, and you can see in a vast area. In North City and County, extending over to the east side, you can see that there's you can't find a region where there are more than four loans per 100 houses in this time period of 2012, 2014. It's a desert of loan applications. And as a consequence, you have this inability to generate wealth in these homes. And then you consequently have this focus on persistent inequality and poverty. We talked about this before. Now, let's pivot again and really talk about what we're doing as a region to address these issues. I mentioned about the St. Louis Partnership for Healthy Communities. We came together and said that we can do this, as across all these municipalities. We have to overcome this political fragmentation. And the goal was to improve the availability, acceptability, and affordability of integrated and coordinated patient care, centered care for most vulnerable populations in St. Louis City, County, and city through policy, system, and environmental changes. That's a big, that you can say that's aspirational. Well, I don't think that's aspirational. I think that's very attainable if we do this thoughtfully, and if we continue to do this meaningfully. An organization was created, Think Health, which really helped to guide the St. Louis Partnership together, particularly around data management and implementation and operationalization of the Think Health initiatives. And I just want to highlight 3 priorities which were identified. First, let's address the social determinants of health as root causes of community health. Second, eliminating health disparities and promoting health and racial equity. And third, improving the public health system to be able to collectively address the needs of the region. We have 2 health departments, right? St. Louis City, St. Louis County. We're coming together, working on shared services for the first time. And it's a beautiful thing to see. I think that we're going to actually have some really remarkable outcomes with input from a regional planning group, but equal input from community advisors. This is an equal opportunity initiative. Where those from the community sit at the table and they carry equal weight in this discussion as we galvanize these action teams that you can see in the middle. Behavioral health and violence prevention, maternal child health, and others. I don't have time to go through all of the data that's been generated by the St. Louis Community Health Partnership and Think Health, but I wanted to highlight these 3. So again, when I said that when we look at the health of our community and the disparities, for the most part, this is a Black-white dynamic. And let's take a look at that first panel, the opioid-related deaths by race and ethnicity. And you can see the rates of African Americans compared to white group. Look at the age-adjusted ER rates due to uncontrolled diabetes. And you can see where we are with the African American community. And the last panel, age-adjusted ER rates due to mental health by race and ethnicity. And you can see just a wide, just a remarkable difference here. And recognizing that many members of that community really suffer from prolonged cumulative stress and are more in need of mental health, behavioral health support. Okay. Now, third pivot. Let's go deep. Let's go deeper and talk about why did we get here. We're going to finish in about 5 minutes because I want to have time for questions from you. After the Ferguson protest, I had an opportunity to go visit a church there with a colleague who was a minister. And I sat in the back, and I one of the member of the Post-Dispatch saw me, the newspaper. He came and he said, "Well, what do you think is really going on?" And I talked about what we just shared, and his eyes glazed over because he wanted, he needed something short and succinct. I said, "I can't give you short and succinct. I mean, you have to understand, that this is going back generations." And he said, "Okay, I'll just quote you real quickly." And like 5 words or something in the article. Well, 5 years later, I was reading the Post-Dispatch, and they were coming on the 5-year anniversary of the Ferguson uprising. And I saw this quote. And the quote, it reads, "It was the intersection of poverty, unemployment, lack of educational opportunity, and deep-rooted racial animosity where the confrontation developed that cost Michael Brown his life." I said, yes, they got it. they understand it. 5 years later, mejor tarde que nunca, better late than never. So So that was important for all of us to realize that we're really beginning to grasp this. You can't solve a problem if you don't acknowledge that it exists. And that was a really important acknowledgement. Let's close now with a focus on St. Louis. How do we get here? How do we get into this dilemma? St. Louis, as we all know, started out as a wealthy city because of the fur trade on the Mississippi River. And as a consequence of of St. Louis in 1904 was the fourth wealthiest city in the country behind New York, Philadelphia, Chicago. It was St. Louis. That's why the World's Fair was here to really showcase in an opulent manner the wealth of St. Louis. Well, that was a magnet for a lot of individuals in the Deep South seeking economic opportunity, particularly African Americans. And this was chronicled beautifully in this book, The Warmth of Other Suns by Isabel Wilkerson, when 6 to 8 million African Americans really packed up and they became immigrants in their own country, seeking greater opportunity. You can only imagine what would happen if they would arrive in a community where there are also low-income whites who may have lost their jobs. This is really 1917, 1916. And what is the worst thing that could happen? Worst thing that could happen would be a racial massacre. I won't say riots, because these were massacres across the country in the same places, not just East St. Louis and St. Louis, but Rosewood, Florida, Tulsa, Oklahoma. I hope we're all aware of what happened in this country. If we don't acknowledge that, then we're burying that history. And so it happened in East St. Louis, and African Americans flooded over across the East Bridge seeking refuge here, but they were told, we'll take those of you who have jobs, who have meaningful employment, and we'll tell you where you can live, and you cannot move anywhere else. And we talked about restricted covenants earlier. This is a map of the 1930 census, looking at the distribution of the Black Negro or Black population at that time. And so this map is kind of on the side of St. Louis City. If you will flip it up, here's the Mississippi River portion along here. You can see that each dot represents 100 Blacks. You can see where most of the Blacks live at that time. There's a dense collection here. Those zip codes I mentioned, okay, you know where those zip codes are. You know, this is 63116, or this is 63117. They were there for a reason. During 1927, here's a map of St. Louis, 1927. I want just to orient you here. Here's downtown here. Here the arch would be here. Here's the Union Station right here. There was a community that extended from immediately west of Union Station all the way up to Olive. This is called the Mill Creek District. And it was largely African-American community. But during the time of the Public Health Works, the Eisenhower administration, that whole community was basically destroyed to make way for the highway and other industrial institutions in that area. And those individuals were displaced. Around the same time, after 1940 or so, rather, a couple decades later, there was a desire to really look at St. Louis. Again, we've been a poster child for what could go wrong. And the goal was to create a housing project in St. Louis where Blacks and whites could reside. That was called the Pruitt Igo Housing Project. It was vast. I mean, just look at the scale of those developments. Nonetheless, they were not invested. There was lack of investment. Whites left in droves after only a couple of years. And in 1972, 20 years later, the whole housing project collapsed. It's almost a metaphor about what happened to this region. All of us are aware of the history of Homer G. Phillips Hospital, which was a remarkable place of anchor for the Black community in the Ville neighborhood, 63113. When that closed, there was a lot of racial animus because that was a hospital that was high quality serving the Black community. And there was never a good reason for why that hospital closed. That anger is still palpable We don't have to go back and talk about the Tuskegee syphilis trial. We don't have to go that far back. We're talking about something that happened, in the late 70s. Now, St. Lawrence Hospital, where were we in this mix? We were, our hands weren't perfectly clean. Here's a picture of Lawrence Hospital in 1915. Here's the main hospital, but you can see there were segregated frame units here, the Negro units. Lawrence Hospital was very embarrassed when this picture circulated. And within a few years, those Negro units were demolished. Unfortunately, African Americans were relegated to receiving care in the basement, right outside of this auditorium, going down toward the ER, then heading east, were a series of wards called 0400. I took this picture just to show you where they were. And they were dreary wards with leaking pipes. And that's where a lot of Blacks received care. There was a ward Children's Hospital in better condition than this. St. Lawrence Hospital integrated in 1965, Jewish Hospital integrated in 1955. And this was the first picture of the integration in our outpatient clinic. And things have gotten better. So let me just summarize that health disparities have to be interpreted in the context of long-standing social and structural barriers that impede vulnerable communities and its individuals from reaching their full health potential. Secondly, healthcare access is necessary but not sufficient to reduce those disparities. We, all of us, have an important role to play in establishing meaningful partnerships in our community as we endeavor to achieve health equity through collective impact. And lastly, all our patients make rational, logical decisions, but they're based on their perception of what are their immediate needs in their Maslow hierarchy of needs. We have to understand their world in order to understand their needs and function more effectively as members of their patient care team. I really feel that we have that power to do that. We have that desire to do that. And I'm really excited that we have this opportunity to have this discussion this morning. Thank you.
Dr. Ross, thank you so much for joining us today, for your talk, and for educating us all on a lot of the history and unfortunately, how current history of the inequities. As I give folks a moment to put some questions in the chat for us, I wonder if you could comment on some of the opportunities for our trainees, our residents, and fellows to get involved, particularly, say, with the St. Louis Community Partnership. We've had our recruitment season recently, and we've had a lot of, fortunately, a lot of recruits asking for what are we doing? How can we get involved, or what's happening in the WashU community? And I feel like we don't have enough to say that we're doing. And granted, we've had COVID, but how can we get involved?
I appreciate that question. And I put this graph here, this chart here, which I didn't go over in detail. And I think here I highlighted some of our community partners. We, Washington University, actively working with these institutions to address community health. And there are abundant opportunities for our residents to serve as volunteers, to serve, to do work in the community, or to even to engage in a scholarly analysis of the impact or the needs of these institutions. They include the Regional Health Commission, and I've had residents work with me in our work there. The Regional Health Commission spawned the Integrated Health Network, which oversees the operations of our community health centers, federal qualified centers. And there are opportunities to work on access to care and work on involving our communities in ways to navigate the healthcare system. Alive and Well STL is an organization that focuses on trauma-informed care. How can you become an effective advocate? How can you receive training to deliver that trauma-informed care? Gateway 180 is a homeless center here, and I know our residents have been very active in working with the unhoused through the Gateway 180. And then there's so many others. The Spot, which was founded by our pediatrician Katie Platts, which offers activities which address the health of our young population. the Independent Center, which works with populations who are dealing with severe and persistent mental behavioral issues, working to craft materials that are appropriate for individuals, populations with low health literacy through the health literacy media. And of course, I put the International Institute, which works with our immigrant and refugee population in United Way. These organizations are thirsty. They are thirsting for an engagement with a remarkably bright group of residents that we have here.
And if you wouldn't mind maybe sending me this slide, at least I'd love to distribute it to everyone, just, as a reference point for us, for organizations we can look into. While I start asking the next question, let me just go ahead and pull up the QR code before I forget for everyone. One of our attendees comments and asks, sometimes they just get so frustrated at these inequities. How do you remain optimistic for change?
Well, I appreciate that also. I remain optimistic for change because I understand the history of St. Louis and the history of this country. Arthur John Meacham wrote a great book called The Soul of America. And in that book, it's a beautiful read. He really talks about what we've gone through from the Civil War, from Reconstruction, from the 1904 versus Ferguson, which ushered in Jim Crow, to the Civil Rights Movement, all through all the wars we've gone through. Now, I guess I can quote Winston Churchill, who said, "Americans will always do the right thing, usually after they've exhausted all the other options." And so I am optimistic. I grew up at the time, and I was mentored by individuals in the Civil Rights Movement in Memphis, Tennessee, in the 70s. And we were optimistic that there were those who would understand, through a moral inclination, that we have to do better. I saw that when a number of individuals amassed to protest the death of George Floyd, and that those individuals were across all demographic groups, and that there was a cascading of events and protests across the country. And I said, a lot of people are saying it's time to change. So yes, I am optimistic to this day that we can change. Here in St. Louis, we can change nationally.
What advice would you give trainees interested in careers providing care to the underserved?
I appreciate that also. I think what we need to do more here in our residency program in medicine, as well as in our hospital, is to provide more opportunities to engage our residents directly with the community. Now, I know there are a cohort of residents in our primary care track who do a little bit more of that. They work with really cool people in our department. I don't think that should just be relegated for that particular cohort. I think it's incumbent upon us to provide that type of exposure to every resident in this program. You won't know what's going on in the community until you work in that community. And I think that when you get into that community, you'll align with others outside of medicine and all these other health-related fields and social fields, and you'll realize what you can do. But you have to get out first. We have to create a virtual medical center and actively work in the community.
This, I guess, not so much a question as a comment. They just say such an amazing conference. So important that we understand our community, our patient population, and our history. They said, please continue to spread this information for our trainees and beyond, especially for the many who are not here, St. Louis natives, but train and live here. So more of a thanks there. And the question here, and I recognize you're in the division of nephrology, may be unfair, but what would a public health rotation look like in St. Louis in your eyes? What would be ideal?
I'm also an epidemiologist, so we can strive both worlds. And I think a public health rotation would involve spending a week on a particular public health intervention at the city or county health department, maybe sitting in on our Think Health meetings and saying, you know what, I want to work on this initiative to address violence prevention and really look at this group called Cure Violence, which has been brought in to create neighborhood advocates to do violence abatement. Or they want to work on the infant mortality initiative, the Flourish initiative with Generate Health. Or maybe they can spend time at any of these institutions I mentioned, community-based, looking at what's going on, and then looking at data. Public health is also a science field. Okay, we need evidence-based data, looking at data on the impact and the history and the additional resources. And there are also abundant opportunities to work within our own institution with the Institute for Public Health, and there are myriad really high quality initiatives that are done in collaboration with our other schools across the institution. And so you can go to the Institute for Public Health website and you can look at those initiatives and look at the scholars there and say, I want to work with one of those scholars. I want to work with someone who's looking at nutrition and health in Haiti or Guatemala, or working with our initiative looking at cardiology services in Guatemala with Dr. Victor Bavel and others. There are just so many opportunities that are already there, and I think it would be fairly not easy, but I think it would be really an effective thing to do to create just that, a public health rotation. I await the invitation.
Hope leadership is listening and takes you up on that offer. It's 9 o'clock, so unfortunately we'll need to end our questions here, but I want to thank you again so much for taking the time, for putting together such a wonderful presentation, and for all your work you've done for our school and our community. We really appreciate it.
Thank you so much.